Thank you everyone for coming. I think it was really difficult for her to come, but I thought her history would make a really good point about what we're talking about today, which is ultra-treatment-resistant schizophrenia, and how this is really the most severe form of the illness we have, and there's not much we can do. So I really have two goals today. One is to tell you about ultra-treatment-resistant schizophrenia and what we're learning about it, but also, it's kind of neat that I'm ending. Jimmy started the year talking about something about clinician scientists, so I felt like I should weigh in, and I'll talk a little bit about it at the end, but I really want to kind of show you how I approach it being a clinician scientist. So I showed this slide. This is dated now, it's from 2015, but it kind of makes an interesting point. The paper was trying to say that essentially the Nobel laureates all had medical degrees until around 1950, which is probably around when Watson and Crick made their discovery. And then the Nobel laureates switched to more not having medical degrees. And the point they were trying to make is that we now know so much about biology, it advanced so much, but yet it really hasn't translated into better clinical treatments. And I think, for example, and especially in our field, right, if you think about what's been new, ketamine, psilocybin, cobenfy, like I talked about last year, we've known about them for decades, and none of them have actually come out of our understanding of the biology. And so when I think about this, I want to make sure that when I approach questions, they're coming out of my clinical observations. So this way I know when we address it, and if we can answer the question, that in fact it's going to actually impact patients and improve their care. And so if we think about schizophrenia, it's this heterogeneous disorder. So patients can have positive symptoms, they can have negative symptoms, cognitive impairment. Some patients I put on medicine, they go back to work. Other patients, unfortunately, fail every medicine, including clozapine, and can't function. And so it really suggests to me that there's a different pathophysiology, and that there's multiple pathophysiologies. And for example, if you think about, if we lump everyone together, just simplifying it with the gray and the red, you can imagine if there was a really good medication for the people in red, but we tested it in everyone, it would look like it failed. And so it's been really hard to develop biomarkers and inform treatments. And so for my clinical experience, one way I think about how can we get more homogeneous population of patients? And one way is by treatment response. And in particular today, my interest is in ultra-treatment resistant schizophrenia. And the idea is that we have a more homogeneous population of patients, we may be able to identify biomarkers, pathophysiology, and then we can identify informed treatments. So if we think about the different clinical subtypes of schizophrenia, so about 70% of patients respond to antipsychotics, and they're considered to have non-treatment resistant schizophrenia. And unfortunately, about 30% fail, and they're considered to have treatment-resistant schizophrenia. And the only medication that's indicated for treatment-resistant schizophrenia is clozapine. So about 60 to 70% of patients will respond to clozapine, but really, unfortunately, about 30 to 40% don't respond to clozapine, and they're considered to have ultra-treatment-resistant schizophrenia. So when I talk about ultra-treatment-resistant schizophrenia today, I'm talking about patients who are on clozapine, who have essentially failed multiple medicines, are put on clozapine, failing clozapine, and have at least moderate or more severity in their symptoms. I would also make the point that while we focused on positive symptoms, because that's really all the medicines work for, I think as you saw here, ultra-treatment-resistant schizophrenia, we need to consider cognitive impairment and negative symptoms. And I'll have some data to suggest that I think cognitive impairment is probably really part of the syndrome. So I want to make 2 points about why this is important. Obviously one, patients aren't doing well and we need to address it. But here I usually present this as sort of a positive, right? So we've been following patients for over a decade in our clinic, and we've been following the positive and negative symptom scale, which is essentially how much symptoms they're having. And what we've seen is that we look at 2 things. We can look at how many people now have mild symptoms or had a 20% improvement, which would be considered clinically significant in this population of patients. And what I'm proud to say is that 81% of our patients have achieved at least one of the 2 milestones and are doing well. However, as in the case today, it also means that 19% of our patients are not doing well. And this is given the best care. I mean, as I said, this is really, I consider a center of excellence. Patients are put on clozapine early on. They all have therapy. I have data that therapy can actually improve symptoms. they're monitored, they're engaged, and yet we can't impact it more than about 20%. There's still about 20% of patients. The other interesting thing we found, since we've been following patients for over a decade, every 6 months we do the PANS, which is the Positive and Negative Symptom Scale, so they're symptoms. We also follow the Personal and Social Performance Scale, which is how well they're functioning, and then the WHO Quality of Life, which is their assessment of how their quality of life is. And what we were able to do is we essentially did a lagged analysis. And so we were able to say, so if something happened at time X, if there was improvement in time X, what happened at the next visit, which is time X plus 1, and what happened at the time after that? And so you can actually determine the cascade of what happens first. And what we found out is that first patients' symptoms improve. And if their symptoms improve, then their functioning improves. And if their functioning improves, then their quality of life improves. And so, interestingly, that seems to be more the case with relationships than socially useful activities. So particularly relationships seem to be important to patients. But what this suggests to me, that is, if we aren't able to impact positive symptoms, then we're not likely to really improve functioning or quality of life, unfortunately. So there's very little known about ultra-treatment-resistant schizophrenia. Most studies still compare schizophrenia to control. Sometimes they'll compare non-TRS to TRS, but very few studies actually compare TRS to UTRS. So this is one of the main studies used to kind of suggest that there may be different pathophysiology between at least non-TRS and TRS. But in this study, they didn't have people on clozapine. They just failed 2 medicines that were in the study. So this treatment-resistant group includes TRS and UTRS. And so there's really no way to separate out which is driving these differences. But what's interesting is if you look, they looked at the striatal dopamine synthesis. And as we know, the thought is if you make too much dopamine, you develop positive symptoms. The neuroleptics are D2 antagonists, so they lower dopamine. And what they saw is that, in fact, responders had significantly more dopamine synthesis than treatment-resistant or healthy controls. And then, in fact, treatment-resistant were more like controls, which probably explains why giving antipsychotics to people who are treatment-resistant doesn't work, and trying the second, third, fourth, fifth antipsychotic's not going to make a difference because they don't have elevated levels of dopamine. And what they did look at then is in this study, it's the same patients that I just showed you. Not all of them came back for the study, but many did. And in fact, what they showed is that the treatment-resistant group of patients had increased anterior cingulate cortex glutamate levels, and that was replicated in another study. So again, this suggests that there's a different pathophysiology, but we can't really determine whether it's TRS or UTRS. I would argue maybe UTRS is actually driving these results. And so, really the little bit of other biology that's known, there's a little bit of neuroimaging data suggesting that there's lower prefrontal and thalamic perfusion, and magnetic resonance spectroscopy studies showing that there's higher mid-cingulate GABA levels in UTRS. But these studies, there's very few studies, they're small, they're limited, and they need to be replicated. So we really know very little about what it means biologically to have ultra-treatment-resistant schizophrenia. This slide shows all the biomarkers to predict ultra-treatment-resistant schizophrenia. Unfortunately, it also shows all the treatments for ultra-treatment-resistant schizophrenia. So we're really in a bad shape here. We don't know much about the biology, we can't predict who's going to get it, and we don't have any treatments. Of course, people have tried to augment clozapine with medications. There's very little evidence that it's helpful. Probably what would be considered the most helpful would be aripiprazole. But to be honest with you, in my experience, I've tried all these things and they don't help much. So the best thing you can do is make sure you optimize clozapine, make sure they're taking it, their levels are high enough, and that they're on it for enough duration. So we also showed that many patients don't respond until after being on clozapine for over a year. The one study that was promising and which led to the treatment that we gave was that augmenting ECT with clozapine can be helpful. So this was a nice study done in 2015 where they randomized, it was a randomized single-blind 8-week study with 39 patients, and they compared clozapine versus ECT. And they actually used an improvement of 40%, which is a pretty high bar. So, we consider a 20% improvement clinically significant. So 40% was a pretty high bar. And what they showed is 50% of the patients responded to ECT plus clozapine compared to 0 if they just stayed on clozapine alone. If you look at this graph, the green shows clozapine, the orange shows clozapine plus ECT. And they started to see a separation at about 3 weeks. And then this is looking at positive symptoms. And there's clearly a clinically significant improvement here. They also saw clinically significant improvement in clinical severity, but no improvement in negative symptoms. Now, this was promising, but as you kind of heard, so in my experience, I started to utilize ECT more in our ultra-treatment resistant patients, and unfortunately, while I do see improvements in their symptoms, it doesn't last. So I bring patients in, they get ECT 3 times a week, we wean them to weekly, we continued on an outpatient basis, and as I try to wean them from weekly to bi-weekly, sometimes they do okay. As soon as I go past bi-weekly, their symptoms return. And so it's been a really interesting situation because the patients continue to want to go, which is how she ended up with so many ECT treatments. It was the only thing helping her. But, it's what quality of life is getting ECT weekly. I don't know the long-term consequences of that. And so really, practically speaking, I don't find it so useful, and I've started to move away from that approach. I think sometimes symptoms are exacerbated by mood symptoms. I've seen that happen where we give ECT, the patient does better, and they kind of go back to baseline. But true ultra-treatment resistance and psychosis, it seems to impact it but doesn't last. So we need other treatments. So what are the areas in need? Well, we need to determine whether UTRS represents a more severe form of schizophrenia or a biologically distinct subtype. We need to identify biomarkers and clinical parameters that predict clozapine non-response, elucidate the biological mechanisms, and develop novel therapeutic treatments. So one way to think that we're thinking about this is we've been doing this study for about 3 years now. We're getting close to 80 patients, I think. And so the idea is that we're going to have those homogeneous populations of patients. We're going to actually study UTRS patients, and we're going to compare them to TRS, non-TRS, and healthy controls. We're going to do this cross-sectionally and longitudinally. So we'll do these measures before they start clozapine, and then 6 months and a year after being on clozapine. And the idea is if there really are differences, if ultra-treatment-resistant schizophrenia has a different biology, we should be able to see differences in clinical cognitive measures, EEG, imaging, and neurobiology. And so I won't go through all these, but we're doing a deep battery of clinical and cognitive testing, including functional capacity assessments, which I'll show, olfaction, a whole battery of MRI testing, EEG, resting state, and visual, and also collecting biospecimens so we can actually try to map out the pathways and therapeutic targets. So in this study, we looked at functional capacity, which is the ability to perform real-world functioning, and cognition. And we compared clozapine responders to non-responders. And what this is basically, it's a computer simulation. So you actually go up to, it was a touchscreen computer, so it's very much like doing the task. An ATM pops up, you put in your PIN, really no different on a screen versus an ATM screen. And it would ask questions, and the tasks were ATM and paying your bills, refilling your prescriptions, and purchasing a ticket to go across the city. And so the questions would start out easy, but they would get harder and harder. For example, the medication refill would be, you've been taking medicine for a week. You've been taking 5 milligrams of your medicine for a week. Your doctor increases it to 10 milligrams. How many more days of medicine would you have left? And what we found is, here I'm just showing, we had a number of measures. I'm just showing the correct responses. But what we saw is patients who responded to clozapine did significantly better than those that didn't. And so, for example, in the refill, patients only got about 45% of the questions right if they were not responding to clozapine versus 80% if they did. So suggesting that maybe functional capacity is a marker for ultra-treatment resistance. And then we did the standard battery of cognitive testing, and it turns out that patients who responded to clozapine did about 3/4 of a standard deviation better than those that didn't. Now this is cross-sectional, so it's hard for us to say whether clozapine improved these measures, or in fact, is this a candidate biomarker where people who perform poorly on these tests are likely to be ultra-treatment resistant. I should also say that these tests, what's nice about these tests is we're also trying to come up with some things that are kind of simple to do, right? Each of these tests takes about a half hour and can be done in the clinic pretty easily. Another thing that we can do is EEG, which is also non-invasive and inexpensive, can be done at the bedside or in the clinic. And it measures synchronous activity across large groups of neurons. While it's not so good at measuring, identifying brain areas and regions, it is very good at fast dynamics. And so there's a couple of things that you can learn and look at with EEG. One of those is frequency bands. So there's 5 frequency bands. They all reflect different neuronal functions, but interestingly, they've all been shown to be disrupted in schizophrenia. However, most of those studies were comparing schizophrenia to control and not these subtypes. What I find particularly interesting is gamma happens to be one the data is very inconsistent, which may suggest that in fact the population of patients in the study really impacts the results. So if you have a lot more ultra treatment resistant patients in the study or less, it may be why they're getting inconsistent results, and I'll show you why in a second. So this is the EEG. This was done by Ander Botner, our fellow here. This is just resting state, so the person's just sitting there with their eyes closed, and they're just being recorded. And interestingly, 2 of the waves may be able to help us sort out treatment response. So if you look at theta, we see that, so this is healthy controls, non-TRS, TRS, and UTRS. And what we see is healthy controls and non-TRS look very similar. And I should say these are topo maps. So each dot represents the electrode. The warmer the color gets, the red, the more spectral power that you see. And so what we see here is that non-TRS and TRS and controls look very similar. But the TRS and UTRS patients look very different. Now from this, we can't necessarily predict who will respond or not to respond to clozapine, though it may suggest who will respond to medication. If we look at the gamma wave, we see now that healthy controls, non-TRS and TRS look very similar. But in fact, at the gamma waves, UTS looks very different. UTRS is very different and has a much higher frontal gamma power. So now we may be able to actually dissect between these 2 bands who's going to respond and not respond to clozapine. I caution that this is not many people. You can see here each dot represents a person, so we're about 15 patients per group, which I know is not a large number, but what we have seen is as we've seen this effect from the beginning, and as we've increased the numbers, we've actually gotten better results. So I do think that this is going to hold up, but certainly we need more patients, and we're actively recruiting. The second thing we can do is we can get ERPs from patients, so we can actually see how the brain is responding during a task. And so the task is also can be a stress for patients, so maybe something else will emerge. And so here I'm showing the congruent task. This is the auditory Stroop. So a person will hear the word left in their left ear and they have to press a button. They'll hear the word right in the right ear, and they have to press the right button. And so here I'm just showing the congruent task. So essentially this is probing auditory attention. And once again, we see a difference with ultra treatment resistant schizophrenia. So essentially here what happens is you hear the word left in your ear at time 0, and about 300 milliseconds later is when the brain normally has a response. And we see ultra treatment resistant schizophrenia has a much exaggerated response compared to the other groups. And now this is actually not suggesting that it's processing better. What it's suggesting is that the brain is working hard but not more effectively because we actually have the behavioral data, and the ultra treatment resistant patients were inaccurate. So they missed more, they got it incorrect more often but had a bigger response. So, you know, these are 2 possible candidate biomarkers. Now we may be able to put an EEG on your head and be able to determine your treatment response. But that's sort of very rudimentary in a way. We were lucky enough to connect with Dr. Sri Sarma, who's a computational medicine at Johns Hopkins, and she's developed a method that can actually help you determine how brain regions influence one another. So essentially each electrode is a node, and how do they communicate with each other? And it's a complicated mathematics that I don't understand or go into, but I can give you the general idea of it. And she's actually been able to show in seizure disorders they were able to predict who will respond and not respond to seizure medicines. And the idea is this is essentially how are the nodes communicating? And so if something's a source, if it's an ideal source, it means it's putting out information. If you look at 3, it's only it's only putting out information, it's not receiving any information. And if you look at the sink, that is only, the ideal sink the source is only putting out information, and the sink is only receiving information, so number 2. And then 1 and 4 are kind of in between. It's receiving some information and giving out some information. And so we use this to try to get a sense of how, is there actual connections, differences that are happening in ultra-treatment-resistant schizophrenia. And what's really interesting, if you look at healthy controls, so this is essentially, the blue is essentially the parietal region, and the red is the frontal region. And what we see is that the parietal region is communicating with the frontal region's communicating back, less so, but it's communicating. But when you look at ultra-treatment-resistant schizophrenia, you see this stretch. We see that now these corners would be where this is now more in both corners, which means in this case the parietal region is sending out information, but it's not receiving information, and the frontal region is receiving information but not sending anything back. And so this seems to be disrupted. So try to make it simple. Essentially, it'd be like, in the healthy, it'd be like someone's talking to you, and someone's responding back kind of minimally, but they're answering your questions. But in ultra-treatment-resistant schizophrenia, you're talking to someone, and you start talking louder and louder and louder because they're not answering, and they're not answering back. And so I kind of want to weave in some clinician scientist stuff as we go through, but what I think is Jimmy presented this at the beginning of the year, this idea of clinician, scientist, and scientist. I think this is a great example of how at least a clinician, scientist, and scientist connected. So I could never understand the math that she's doing. In fact, we interviewed a student together, and she had them deriving calculus equations in their head, so it was quite impressive. But of course, she was looking for a data set to compare controls to schizophrenia. And if you look at this, you could imagine if we merged everyone together, we may not see any signal, or certainly we wouldn't know that it's actually the people who are not responding that are different. So there's so many ways that, obviously being a clinician scientist, being able to identify the right patient populations and helping scientists connecting is going to make more impactful science. So you may say, well, how could leads on the head, how could it really determine what regions, the parietal and frontal, just from leads on the scalp? So it turns out we also did imaging on these patients. And so this is fMRI, which shows how regions coordinate activity. And we looked at the frontal parietal attention region. And it turns out that, like we saw in the EEG-DNM, the connection is reduced. So if this were a good connection, the colors would be red, would be yellow, orange, red. And so essentially there's impaired connection between these regions. So suggesting that the frontal and parietal regions may not be communicated efficiently, leading to impaired intention, maybe slow cognition, and disorganized goal-related behavior. But this does really confirm that what we saw from the EEG and her mathematical the process that she did can very well predict what's happening in the brain. And so maybe, again, we can do this at the bedside, and we don't have to go through complicated MRI imaging to make these decisions. So it's nice that we're seeing this link together. I wish today I was going to talk, I'm not going to talk so much about my protein aggregation work, but I bring it up for 2 points. One, we do have the cells, so we have iPS cells from all these patients, so we are going to be able to study what pathways are different, and I have some ideas about how we're going to approach that. But I bring this up for 2 reasons. One, the fact that this fact that we've identified protein aggregations came out, again, out of my clinical experience, right? So the idea is how could schizophrenia is a developmental disorder, it can't have anything related to neurodegeneration, but when you see ultra-treatment resistant patients, when you see patients developing dementia over time, it becomes clear to you that there is probably an aging or neurodegenerative component to it. And so we have shown that similar to Alzheimer's and Parkinson's and Huntington's, that there are protein aggregates in some patients with schizophrenia. The other point is that we can actually link this back to clinical and cognitive measures. So patients with protein aggregates were more likely to have cognitive impairment. And so you may say, well, if the patients who have poor cognition are ultra-treatment resistant and they tend to have aggregates, perhaps the patients who have protein aggregates, it may relate to ultra-treatment resistant schizophrenia. I don't know if that's the case, and it's a stretch, but these are things that we can answer. And by having these cells, we're going to be able to map out pathways and I hope have informed treatments. So there does seem to be an emerging biological signature for ultra treatment-resistant schizophrenia. Clinically, they have poor cognition and functional capacity. There's changes in EEG that also relate to fMRI. And so I think conceptually, although preliminary, these findings provide evidence that UTRS is biologically and clinically distinct subtype. I also think maybe multi-omics will work if we can compare EEG, fMRI, cognitive measures. If we can combine them all, we may get a much better signal and prediction of who's going to be ultra treatment resistant. And so these are the things that we're headed towards with this study. And then obviously, can't wait to get to the cells, where that's sort of the next phase of this, is working with all the cells we have from the patients. So I was hoping today I was going to come and talk about this exciting study on evenamide, which is in clinical trials. It's a new mechanism, a voltage-gated sodium channel blocker. It was promising. I have to applaud the company. They're one of the only companies that's been willing to actually not only take on treatment-resistant schizophrenia, but they were willing to have 30% of the patients in the study who failed clozapine, which I'm not aware of anyone being willing to have done that. And just in the last week or two, there was a death in the study that appears to be unrelated. I don't know much details, but the FDA put the study on hold. And so unfortunately, that's one of the reasons we stopped ECT, and they were pretty, I would say almost devastated that they didn't have this opportunity. So, what is another option is deep brain stimulation. So Nicola presented grand rounds on this, so I'm not going to go into details, but I think right now this is probably one of the most promising treatment options. This is from his 2021 case report, a 35-year-old woman, where they were actually able to show that they could reduce the symptoms from really severe down to essentially not, at least hallucinations, down to not present. And so actually after this, we're going to meet with, our family and I and Nicola are going to meet to discuss moving forward with deep brain stimulation. I'm really hoping that she'll get some relief. So just to summarize, UTRS patients remain severely symptomatic despite optimization and clozapine treatment. UTRS is associated with marked cognitive and functional impairment. There remains a critical lack of biomarkers and mechanistic treatments, EEG, DNM, and fMRI converge, and there may be problems with frontal parietal attention. And this supports the idea that this may be a distinct subtype. I do want to make a couple comments at the end about clinician scientists. So, I think there's been a little bit of a debate about how important, what's happening with clinician scientists. Can we sustain this? But, people take both sides. But I think the issue is not really is the beaker half full or empty. I think we really need to talk about, what's in the beaker and what is the beaker itself, right? So clinician scientists, we always, we put a hyphen there as if they're one word, but in fact, they're very different skill sets, right? And I always try to press upon a person, you have to be very good at both to be successful. And I always, when the residents would come to or medical students would come to interview, I try to explain to them, you don't want to shortchange your clinical training. If you took the time to get a PhD, you've got to be good at clinical, and most of them just kind of roll their eyes at me and want as much time in the lab as possible. But I think it's critical that the clinician scientists, that they understand that they've got to be good at both. I think we obviously have to give them the best support we can, the mentors, the department. I think we have to think about how can we over-support them, because if we're going to ask them to put in this time, we have to do the best we can to support them. Certainly the NIH, I've had numerous conversations with POs who tell me, we really care about clinician scientists, we want to support them. And then, I've seen a number of people not get the support they need. And so, maybe we need to start communicating with the NIH and making them aware when people are vulnerable. But basically, if we're going to ask people to take 10 more years of their time to train and to do this, then we have to provide them with the best support possible. And really, I'm saying all this because I think at the end of the day, I don't see how we get from schizophrenia to ultra treatment-resistant schizophrenia, or schizophrenia to, could also be aging and neurodegeneration, to biomarkers to inform treatment without clinician scientists. So, and if anywhere is going to support it, it has to be Hopkins. And I have no doubt that Jimmy and future chairs will continue this. I have a lot of people to thank, amazing clinicians who help take care of the patients, and they're doing better because of them. I just mentioned Andor, the people in the lab. I do want to thank my mentors, 30-year mentors who've helped me through all different times and struggles, and I have to really thank Ray, Tim, and Jimmy, who have found a way to keep me going, you know, and no matter how tough the times were, with or without funding, they kept me going. So I thank you so much.
Thank you, Fred. That was a great talk, and it is a pleasure to support such interesting, important, valuable work. I want to ask you this. You mentioned evenamide, and you talked about how it looked like they were going to study ultra-treatment-resistant patients, see if evenamide worked in that subset of people. What about Cobenfy? Is there any data yet on whether Cobenfy works in ultra-treatment-resistant?
Yeah. So there isn't. So in fact, we had put in a study, an investigator-sponsored study, and they had accepted it. We had several meetings with them, and then they decided they didn't want to be in the treatment-resistant or ultra-treatment-resistant business, and I think are headed towards first episode. So the answer is we don't know. You know, we haven't used Cobenfy a lot yet. I don't think it's going to be so impactful. Also, if you think about it, clozapine is the only antipsychotic that has muscarinic properties also, and that may be part of why it's superior. I don't know that adding Cobenfy is going to matter. Also, interestingly, Medicaid, I think, wouldn't, at least at one point, wouldn't allow you to have people on both. I don't know if that got changed, but when you filled out the prior auth, you had to check that they weren't on clozapine, which is actually very unfortunate, I think. It may be worth certainly trying.
Interesting. Okay. Folks have questions. Dr. Sawa.
Thank you.
I have one question and one comment. And comment is to including Jimmy people. The question is, in Europe, many people utilize anesthesia is almost closely good to product. So how are you, so then we are now discussing when you just now, how are you going to consider anesthesia in collaboration with European people to have a big picture of better treatment for schizophrenia? This is my first question.
Yeah.
So talk about amisulpride.
Yeah, I mean, obviously we have no experience with it because it's not available. You know, I wish it were. I actually do hear that it's in clinical trials. There may be a version coming to the States. I don't think it's going to be better than clozapine. Maybe it has less of the side effects, but I think it's important to have meds that are sort of more on the efficacious side. The field has kind of moved towards less side effects, less efficacy. So I think clinicians are going to kind of see it like Zyprexa and clozapine and maybe shy away from it a little. I think it's going to be advantageous for us. But again, ultimately, I think there's a different pathophysiology for ultra-treatment resistant, and none of these dopamine meds are going to do it.
So, Kira, let me just say time is short, so I want to see if other people have questions, and maybe we'll come back if there's more time. Dr. Sedlak.
Thanks very much, Fred. A general question about how you conceptualize looking at biomarkers for the ultra-treatment resistant group and how they obviously have different treatment experiences, medication trials from the past and current medications. How you disentangle what
Yeah.
medication biomarkers versus medication history biomarkers.
Yeah.
It was relevant when we worked on the neuron trial together, and also relevant to all of psychiatry, about subgroups of thoughts on that.
So how do you disentangle markers of illness versus markers of treatment, in the sense, the impact of treatment?
Yeah, I mean, those are hard questions. In some ways, I'm not sure that we can. Certainly, doing the before and after study or having everyone on clozapine, in some ways, I think, addresses some of that. Past history is really hard to address. I think we've looked at our patient population, and I don't know if their medication history was all that different, but it's a great question. I don't know that I have an answer, but something we do need to think about.
Yeah, that kind of thing comes up a lot, and it can be hard to disentangle. Dr. Moran.
Great program, Fred.
Thank you.
You showed us data that clearly provided a differentiation between treatment resistant and the ultra-treatment resistant. As examples, so when you looked at what the raw data was, there was overlap there. Do you think it's going to be one test is going to differentiate eventually, or do you think it's going to be necessary to combine data and to scale from that standpoint?
Yes, yeah.
Will we get one test that differentiates, or will we need to combine
Yeah.
across several tests?
I'm kind of thinking, that's kind of the point. I'm kind of thinking we may need to combine them. I don't know that any one is going to tell it. I think almost definitely it will be stronger to have multiple. I do think there's something about cognition, but in and of itself may not be enough. So that is the idea. If we have multi-omics or multimodal, sorry, is what I've been trying to say. I think that will be advantageous. And I like the idea, though, the more simple they can be. If we can do, things, paper and pencil tests, put a cap on someone, and we can get somewhere. That's really not hard to do.
Mm-hmm. Great, thanks, Dr. DiPaolo.
Thank you, Fred, for your work and for this talk. The question I would ask is similar in a way. Looking at the trajectory of the patient's illness before they became ill with schizophrenia, we could define. This patient had a learning disability, needed an IEP. Does that help? Those kinds of things?
Yeah, no, I think that's a little more unusual, but I mean, in some ways, fortunately, our patients are doing pretty well. I didn't have a lot of other patients who really made the point like she did and went through ECT. So now, again, I do think that we may identify cognitive impact earlier on. And I do think that we see that a lot with ultra-treatment-resistant schizophrenia. But it does vary, and some people are refractory from the beginning, some people develop refractory. So it's complicated, and there may be even subtypes within this subtype, but I kind of, I'm trying to tackle as much as we can, basically. Yeah.
Other questions? Dr. Taylor. Do the ultra treatment resistant cases have a unique genetic profile?
Yeah, we don't, again, studies don't separate this out, they just lump everyone together. So we don't have that information. You might predict they're gonna have a higher PRS score. I always wonder if, when they lump them together, is everything really being driven by ultra treatment resistance and not the treatment resistance? In my experience, the people who respond to clozapine are doing very well. Sometimes I think they may actually be doing better in many ways than the non-TRS patients. So I think ultra treatment resistant drives much of what we see.
Okay. Anyone else? There's one more minute, so back to Dr. Sala.
Yes, thank you very much for coming back to me. So my comment is related to the physician scientist. So people always say support for physician science is very important, but support is usually in very early stage. But for physician scientists, the most support may be needed in the middle to the late career stage, because they have many responsibilities to manage larger projects in collaboration. So just I'd like to mention this point to people. As a result, many physician scientists at the beginning come out to be researcher or give up research. Give up research. Be a researcher or give up research. But Dr. Nucifora is struggling and working very hard to instill as a central player of physician science. So I really admire Dr. Nucifora and
Thank you.
have a great understanding from the department.
Thank you. Thanks,
Thank
Akira. Yeah, so you want to comment on that? Right, there's all this emphasis on the career development support, for the early investigator. What about further along?
Yeah, that's a
And
good
of course,
question.
there are K awards for mid-career people as well.
But I think, I think we see a lot of success in people getting Ks, but it's that transition and after that's so challenging. And all I can really come up is we have to find ways to over support people. Maybe we have, well, I don't want to say less because I don't want to ever limit someone from being able to do this, but I think we really have to find ways to over support people and consider it, as Akira's saying, throughout their career, because it's a challenge. The amount of clinical time, I can't tell you the amount of clinical time this is, and these patients, I get calls every day, all the time. There's a lot of work that gets put in that doesn't get counted into your percent effort. So
True. I'll make just one last comment, which is in support of your referencing the idea that clinical excellence is required for clinician scientists as well as scientific excellence. I'll reference Jake's excellent editorial that I played only the tiniest role in supporting in the JAMA Psychiatry about 2 years ago, which was about exactly that point, that training clinician scientists requires training excellent clinicians as well as excellent scientists, which is a relatively rare concept. There is so much emphasis on the scientist part.
And I think that's one of the strengths of the department. Is I think it's good that we have the tracks, but we haven't really given into it's still a priority that the clinical training is a priority here, and they get the best training without a doubt.
Good note to end our year's grand rounds on. Thank you so much.
Thank you, everyone.